to everyone in Amsterdam, unfortunately not live. And I thank the organizer not only for giving me the opportunity to give this talk, but also to help in the organization of the rheumatologic sessions. We have 3 rheumatology sessions today. This is the first session, and I will moderate the session. We have 2 fantastic speakers, Professor Kirsten Minden and Kirsten HEDRICH. I will start the session with my talk, which is physical examination in pediatric rheumatology. Actually, at the beginning, being a live conference, I had planned to bring an actual child, because this was the meaning of teaching physical examination. This is not possible, so I will have videos, and I will try to explain some hints into the physical examination of a healthy child. And of course, being a rheumatology session, the examination of the healthy child should follow by the examination of a child with a rheumatologic condition, in particular with inflammation of the joints. So it is a video of myself examining a child, and unfortunately it is in Italian, so I will cancel the voice, my voice, and will speak live on my talk. So this is an example of a physical examination of the joints of a healthy child. And I will have to cancel the volume. Okay. And I fake that I am speaking myself in this lecture room with this school-age child. I usually start the physical examination from top to bottom, head to toes, but this is a choice of the examiner. I tend to have the mother with the child. If the child is very young, the child should be comfortable, without clothes, just with underwear and a t-shirt at the most, in order to be able to examine every single joint. At the beginning, when I examine from the head, you see, I make a head extension. The head usually needs to be extended and flexed up to the chin touching the chest. Then I put again the head straight, rotation on one side and on the other side, and usually the rotation should be up to a frontal plane. This tests cervical spine on one side, on another side. As pediatrician, we are used more to flexion because of meningitis, but in rheumatology, sometimes it is extension which is limited. Now, opening of the mouth is testing of the temporomandibular joints. These joints are frequently affected in chronic arthritis, and they are very important because sometimes it is a neglected joint and it can leave permanent disabilities. The way to test this joint is to have the child open and close the mouth many times. You can actually palpate with your fingers the temporomandibular joint, as I am doing now, and you will see and you can feel sometimes even the fluid in the joint. You can feel some cracking, some noises of the joints. When the child opens his mouth, the opening should be symmetrical from both sides and should be wide enough and not limited. One simple rule that I will show soon in the video to test for mouth opening is to check the 3 fingers in the mouth. So you will have the child insert 3 fingers in his mouth wide open. As the child grows, the opening of the mouth grows, the finger will grow. So it is a simple rule of thumb, which where you can actually see the limit of the opening of the mouth. And now we go back down to the caudal examination with the sternoclavicular joints. This is another joint which is frequently neglected, frequently affected. in arthritis, in chronic arthritis, and sometimes in other conditions such as recurrent osteomyelitis. You can actually, as I see now, as I show now, palpate the joint, and you can feel the fluid in the joint itself. Sometimes it's just painful. Sometimes you can see the swelling of the sternoclavicular joint. Then going down the shoulder, to examine the shoulder seems very easy, but there are some hints. The shoulder is one of the deep joints with the hip that is more difficult to examine, because in the more superficial joints you can palpate the fluid, you can see the fluid. Sometimes in the shoulder you have to rely on indirect measure, such as a limitation of motion. It is very important, as you can see now, that you can keep the shoulder fixed with one hand and move it with the other. And the shoulder goes in abduction up to 90 degrees. It is very important that I can keep the girdle fixed with one hand, because if you do not fix it, the whole girdle will move with the clavicle, as you can see here, and it will go well beyond the 90 degrees. But this is not the shoulder joint. You keep one hand on the clavicle, and then the humerus will not go above 90. Then it is internal and external rotation on a frontal plane, as you can see now. Going down on the upper limb, we will go to the elbow and to the wrist and to the small joints of the hand. Each individual joint needs to be examined separately. For the elbow, you can easily palpate the fluid, as I can see you now, as I show you now with 2 fingers. Look at how I keep the elbow flexed, and with my thumb I palpate the joint itself, and my index finger shows where to look for the fluid. Then again, it is extension 180, and flexion, maximal flexion. The hand can easily touch the shoulder, and again in maximal flexion you can either see or palpate the fluid. Going down to the wrist, look here in the rim of the radiocarpal joint. Here, when I show, is where the fluid accumulates. It is very easy to see a synovial cyst or to see some joint fluid, where I'm showing with my finger. And again, keep the hand under the wrist, palpate with the 2 thumbs the wrist itself, and you can feel the fluid. Then there will be flexion 90 degrees, extension 90 degrees, back and forth. If there is inflammation, the child will retract the arm. This child obviously is a healthy child, so the movement is normal and not restricted. And then you have to examine every single joint of the hand, of the metacarpal, metacarpophalangeal, proximal interphalangeal, distal interphalangeal. In rheumatology, it's very important to have every single joint examined, because every joint counts as one in joint counts. And for the small joints, the way I do it is what I am showing you, keeping 2 fingers on one side and 2 fingers up and down. So it is as you have in your hands some grapes or a small bowl filled with fluid, and while pushing on one side to the other or up and down, you can feel actually the fluid. You examine the hand, the palmar surface, the tenar eminence, and you can sometimes see some swelling or some hypotenar or tenar hypotrophy in the cases, for example, of carpal tunnel syndrome. Then I have the child lay down examine the lower limbs. I'm examining now the hip while rolling the lower limb and keeping the knees extended. The limbs are very relaxed. This child can move his hips very well. You can then flex the hip and the knee, and you have to be very careful not to tense the muscle, such as I will show you later in the maneuver or hip abduction. For the hip, let me go. It's a deep joint, as I'm probably telling now. So the palpation is not very useful. Also inspection is not very useful. And again, such as the shoulder, you have to rely on movement. Flex the hip. Look at the video. Flex the knee 90 degrees, and then move this Faber maneuver: flexion, extension, abduction, external rotation, internal rotation. This movement that I am showing now is truly the bucket and ball, the femur, which is rotating without any muscle tension. If you, on the other hand, do what I will show you soon, probably now, let me see. Yes, exactly this. In this case, the child moves the hip very well. It goes flat to the examining table, but you see that the muscle sometimes can interfere. This type of muscle, the iliopsoas, for example, and you can have a restricted motion, not limited to the hip. I will go further with again, let me go further. This is a movement of the Faber maneuver. Okay, let's go to the knee, which is the more frequently affected. The knee is superficial. You can see the swelling. You can palpate the swelling, usually where I am showing here, which is on the medial side. And the palpation and the inspection are often sufficient to show joint effusion. Now I'm trying to squeeze the synovial fluid into the joint. It is very important because sometimes there is extra articular joint swelling, which may be confused with joint swelling. Going down from the knee, I will show the ankle, which actually is a complicated joint, sometimes to examine, especially for young children. It is a tibiotalar and subtalar, and there are also several tendons, and the sheets can be filled with fluid. So in a young child, sometimes just with clinical examination, it is not easy to differentiate intra-articular from extra-articular swelling at the joint level, especially in the ankle. Let me go a little bit further down. Again, here I'm examining the knee. Let's go to the ankle. To examine the ankle, the easiest thing is to flex the knee. I will go like I'm doing here. And then with the knee flexed, you can easily have the ankle muscle relaxed. This I'm still examining the knee, but I want to go a little bit further. And now to the ankle, as I see. Here on the dorsal side, you can see the swelling. You have to move the ankle, dorsiflexion. Here, extension, flexion, extension, flexion. And then when I move it on the side, it's a subtalar joint, inversion, eversion of the ankle. The subtalar swelling is frequently on the back of the ankle, behind the malleolar. This is inversion, eversion. This is the subtalar joint of the ankle that I am moving. Further on, this is where you can see the swelling of the ankle. And this is where you can see the swelling of the subtalar. Further on, we go to the tarsus here, and then to the small joints of the feet, which again, as in the hand, has to be examined one by one. Can go a little bit further. Here I am examining the metatarsal phalangeal joints again one by one, just as I was doing in the hand. Now I have to go. I have to go a little bit further with the second video, just to show you how it might be more difficult. Again, let me put down the volume. How it can be more difficult to examine a toddler. In this case, I have a child in the mother's arms, on the lap of the mother especially, and you have to distract the child, otherwise he will be tense, he might cry, and you cannot examine the joint properly. So in this case, the physical therapist is examining the child. Another person in the front of the child is trying to distract with soap bubbles, and the child is in the lap of the mother. In this case, you have to wait to move the joint when the child is more relaxed and is not retracting the limb. Of course, this is simplified with regard to a full examination. We then have the child, whichever age, walk, see how he walks. This is part of the physical examination. Another part is a muscle examination to check on muscle strength, but it is just a small, let me see, this is again the young child that is examined, and again, as I am showing you, the knee of the young child, and then it will be the ankle. In this case, the mother is distracting the toddler. I have another short video which I want to show you, because this is rheumatology, so I am showing you a rheumatic patient. This is let me take off the music because this was in the original video. Okay, this is a girl with chronic arthritis. You will easily see that the joints are limited. Look, for example, now that she has hypertrophy of the muscles of the lower limbs. She has probably, as I can see, flat foot, and now the examination of the joint is practically the same than the examination of the healthy child, but you see all the restriction in this case when you have a disease. Look at the limitation of the elbows already. She will show that many of the joints are limited, and look how limited is the neck extension. This is a C-spine involvement. She cannot put her head back. She looks, look at the eyes. She look, when you say look up, the eyes roll. The head cannot extend more than 30 or 40 degrees. She's trying again, but she's very limited. Let me go a little bit further to show you. Look at the rotation again of the cervical spine. Shoulders, very limited. Elbows, fixed flexor. The wrists are also affected. She cannot go more than 60 degrees rather than the 90 degrees that I showed you before in a healthy child. Let me go a little bit further down. Just these are some examples. Look at the examination of the wrist of this girl, which even with some strength does not go above 70 degrees maximum in extension, 60 or 70 degrees. And look also at the fingers that are in flexion contracture. The same will be if we go a little bit further down to the lower limbs. Now look at the examination of the finger. Look at the joints. Look at the elbow. Even by pushing, the elbow has a flexion contracture. This is 40 degrees flexion contraction, very severe. Let's go down. Rotation. I hope there is some lower limbs. Yes. Look at the lower limbs. This is a knee contracture, and this is ankle, which even by pushing is very limited. And you can see also some swelling on the side of the ankle. Okay. And here the small joints of the feet, which are very painful, and you cannot see it from. But look at the how the toes look like. So there is swelling here. There is a defect in growth here, and here the physical therapy is putting on some splints. So this was just a short teaching on physical examination, which of course is very hard to do just at distance, let alone in presence, if you do not have the experience. It was not easy for me to speak on myself without knowing what I was telling in reality, but I hope this has been interesting and hopefully an appetizer for the true physical examination, which hopefully we will be able to do 1 year from now, again, hopefully in Amsterdam, and seeing you all. And we will bring an actual child, and I will show you live what I briefly mentioned today with a video. So I thank everyone for the attention. I stop my video, my sharing now, and the question will be at the end of this session. So I will stop my video. I will stop the sharing of the video, and the second presentation, if Professor HEDRICH can share his screen, is by Professor Christian HEDRICH from Liverpool, under Hay, and University of Liverpool. And Professor HEDRICH will speak on non-inflammatory musculoskeletal pain. And Christian, the floor is yours.
Thank you very much, Rolando. Thanks very much to the organizers for inviting me and giving me the chance to talk about this very important topic. And thanks to Rolando for challenging me with this, since that caused quite a bit of pain and headaches to me. I didn't have a talk on this before, and it's a quite challenging one in my opinion. Just to start out, I think it's very important to mention that non-inflammatory musculoskeletal pain is significantly more common than inflammatory pain. So we also in the pediatric rheumatology practice will see quite a few patients who actually experience non-inflammatory pain. Patients with non-inflammatory pain present to multiple specialties, so to family care practitioners, general practitioners, PCPs in North America, pediatricians, rheumatologists, orthopedic surgeons, and surgeons in general, and many more. And therefore, the exact numbers and incidences are not very well known. So this presentation, after some thought, will provide a certainly not exhaustive overview of differential diagnosis, which we need to consider in our pediatric rheumatology practice. I did try to group those differential diagnoses in 10 groups, which I will go through step by step. And I will offer some, but certainly not all, therapeutic options that may be available for them. And I think this presentation underscores the need for a multidisciplinary approach, not only in diagnosis, but also in the treatment and care of our patients. So one problem we are facing quite frequently in pediatric rheumatology is pain that is associated with hypermobility. Hypermobility is actually a very common concern in pediatrics. A number of studies claim that the incidence of hypermobility ranges between 7 and almost 40% in pediatrics. Hypermobility has been classified in the Baton scale that had been modified then by Carter and Wilkinson, and I borrowed that from the Cassidy and Petty Pediatric Rheumatology textbook on the right. Girls are slightly more frequently affected than boys. Overall, hypermobility improves with age, so it's always a good thing to assure and reassure parents and patients that this most likely will get better over time or even completely resolve. There are associations with family history and ethnicity. Indeed, Black and Asian individuals are more frequently affected by hypermobility as compared to white Caucasian populations. And hypermobility can be associated with widespread musculoskeletal pain, and it's more frequent as compared to the general population without hypermobility. One region that is actually exempt or not associated with hypermobility is lower back pain. The pathophysiology that results in pain associated with hypermobility is not very well understood. So there are discussions around joint flexibility itself causing pain in hypermobility. There are claims that proprioception may be altered in hypermobile joints. Microtraumata of those hypermobile joints may contribute to pain. And lastly, that autonomous nervous dysregulation may be involved. There are associations of hypermobility and pain with certain conditions, including reduced muscle strength and balance, which makes sense because reduced muscle strength may keep the joint per se a bit laxer. Delayed locomotor development and developmental coordination disorders have been discussed as well. In pediatric rheumatology, it's always very essential to consider differential diagnosis and exclude them. And heritable connective tissue disorders can be associated with hypermobility and therefore important differential diagnosis for chronic pain. This also is a summary from the Cassidy and Petty textbook of pediatric rheumatology, which is like the Bible for the pediatric rheumatologist. And it summarizes a number of genetic conditions that are associated with hypermobility, some of which you are more familiar with. One of them is Marfan syndrome. Marfan syndrome certainly comes along with certain stigmata. Patients are tall and thin. It's quite characteristic that the arm span is greater than the body height. Patients develop arachnodactyly. They have pectus excavatum and carinatum, as you can see on the right top of this slide. Aortic root dilatation is a common issue, which is why those patients need to be followed by cardiology quite closely. And the lens of the eye can dislocate, which is why ophthalmologists need to be involved. There are some tooth anomalies and high palate that can relatively early on also hint into the right direction. And to, in the end, make a safe diagnosis, we find mutations in the fibrillin gen on chromosome 15. One condition you will face a lot, and quite a number of patients will show to your practice being pre-diagnosed, usually by parents, friends, or family members, is Ehlers-Danlos syndrome. So Ehlers-Danlos syndrome can come along with skin abnormalities, bruising, hyperelastic skin, spontaneous bleeds, and many others. And as you can see down here, there are at least 8 forms of Ehlers-Danlos syndrome, some of them more severe than others. The differential diagnosis we will be presented with most frequently is type 3, the so-called hypermobile type of Ehlers-Danlos syndrome. There are classification criteria for this condition. However, there is no test that actually proves EDS type 3, since there is no genetic association with it. So for that reason, you will see quite a few patients who are somewhat hypermobile in families where hypermobility is an ongoing concern. And you will be asked whether this can be Ehlers-Danlos syndrome type 3. I think this is a very, very difficult diagnosis to make, since most patients will have what we call benign hypermobility associated with pain. In very severe cases, it's still very difficult, in my opinion, since it's a spectrum of hypermobility, and it's very, very hard, in my opinion, to make a cutoff. And in childhood, situations may improve over time into hypermobility, and pain may disappear in teenage years. So therefore, this is a diagnosis that should be made at least very cautiously. One thing we are also experiencing a lot is patients with pes planus or flexible flat feet that can be associated with pain. Flexible flat feet is something you will see quite commonly, especially in infants and young children, since up to 60% of the 2 to 6-year-olds have some degree of flat feet. They also tend to go away over time. They are less common in older children between 8 and 13 years. They're only to be seen in up to 20% of all patients. They usually are asymptomatic, but there can be associations with anterior knee pain, arch of the foot pain, and general foot and heel pain. Treatment usually is limited to reassurance. As I said, it will go away in most patients. Pain will get better over time when the arch of the foot forms. And treatment should only be prescribed if patients are symptomatic, so they have pains. And then insoles are usually the first step. Exercises, especially in the past, have been a tool that has been used. Our physiotherapists here tell me that they can help, but they don't help in all patients. And surgery only needs to be considered in very severe cases that persist to adulthood, because as long as a child grows and a young person grows, this can actually disappear and the arch of the foot can form further. Other than flexible flat feet, rigid flat feet are an actual concern in all patients, and they are much less frequently to be seen as compared to flexible flat feet. Only 1% of the population show rigid flat feet, and in that case, they're usually bilaterally present. They're basically always pathological, and they're caused by fibrous or bony coalition between bones of the foot. They reduce the range of movement in the tarsal and subtalar joints, and usually become symptomatic a bit later in life when compared to flexible flat feet. They start to be symptomatic or become symptomatic after ossification starts, and that's usually between the 8th and 16th birthday. Treatment includes our colleagues from orthopedics and casting and orthosis, as well as physiotherapy, and in some cases surgical excision of those bony and fibrous bars that can be seen also on imaging. In addition to hypermobility, also hypomobility is a concern that we see. It's significantly less common as compared to hypermobility, and it's basically always of pathological relevance. There are also a group of conditions that can actually cause hypomobility of joints and joint contractures, and they can include diabetes mellitus, scleroderma, which is something we are treating in rheumatology as well, mucopolysaccharidosis, and also mucolipidosis, which can look like mucopolysaccharidosis, and I'll get to those a little later when I come to storage diseases, and a number of other conditions, including also what we call rigid spine syndrome. In the past, that group was referred to as rigid spine muscular dystrophy, since a large subset of those individuals also has some degree of muscular dystrophy. And in addition to reduced range of movement of the spine and some degree of scoliosis in most patients, these individuals also present very early on with reduced range of movement in their elbows and elbow contractures. There are a number of lysosomal storage diseases that can result in chronic bone or joint pain. One of them is Fabry's disease. Fabry's disease is caused by reduced levels of alpha-galactosidase A deficiency. It usually becomes clinically symptomatic in boys around the 8th or 10th birthday, and then symptoms become more severe over time. Typical features in individuals affected would be distal extremity pain, so joint and bone pain in hands and feet, sometimes associated with discoloration of those extremities. Boys can develop angiocheratomata. Usually you will find them in the axilla and groin region, but they can be quite disseminated, such as in this patient published a couple of years ago as a case report. In girls, since this is an X chromosomal gene, symptoms are usually absent or much milder. So there are actually girls with distal extremity pain and sometimes discoloration who actually also do have Fabry's disease. And we actually did have a family a number of years ago when I was still in Dresden, in which girls will be affected, and they received enzyme replacement therapy and then were asymptomatic. Another storage disease is Fabry's disease, or acid ceramidase deficiency. This sphingolipidosis can come along with subcutaneous swelling that can happen around joints. So on the top left, this could be interpreted as arthritis of the wrist. Some patients have these subcutaneous nodules that can be around joints and therefore appear similar to rheumatoid nodules. and result in a differential diagnosis of polyarticular juvenile idiopathic arthritis. And we do see bone disease and bone pain in these individuals that is caused by demineralization and erosions of bones that can be seen. I brought images from a patient with mucolipidosis or pseudo-Hurler disease that can be clinically quite similar to mucopolysaccharidosis as well, since these patients can also develop dysostosis multiplex, finger contractures, hip and joint destruction, which you can see here in this X-ray of the hip, elbow contractures, which is not uncommon in some of those storage diseases, in genua valga. A number of metabolic or endocrine disorders can result in bone or joint pain. And one diagnosis I was pretty much sure to never see is scurvy or hypervitaminosis C. So this patient on the right, we diagnosed about a year ago in Liverpool. This is a patient with developmental delay and feeding difficulties. So he was very, very picky with his food intake, and that got worse over the year before he was diagnosed. When he first showed to our hospital, he was admitted to general pediatrics and then hematology and oncology. And what you can see here on the whole body MRI are these signal alterations in long bones in the metaphyseal region for the most part. And that looks very much like chronic recurrent multifocal osteomyelitis, so a rheumatologic condition, which we are very familiar with. So the patient had bone biopsies performed, and those bone biopsies actually showed chronic inflammation of the bone. TB tests were negative, bone marrow was normal, it was slightly hypocellular, but otherwise normal, and therefore he was sent to pediatric rheumatology. And when we saw him a couple of days or maybe a week later, he had these microbleeds in his skin, gingivitis with gingival bleeds, and therefore we thought, well, that's most likely not CRMO because that doesn't fit the bill, and tested vitamin C, and actually he did not have any vitamin C detectable in his blood. So scurvy can be diagnosed with skin or mucous membrane bleeds. Technically, all organs can show some degree of hemorrhage, which can also be life-threatening in some cases, and bone pain and reduced bone turnover, which in this case was the reason for being referred to Alder Children's Hospital. The pathophysiology of scurvy has to do with the role of ascorbic acid, so vitamin C, in collagen synthesis. It's involved in cross-linking of pro-collagen fibers. And on top of that, a lack of ascorbic acid results in DNA hypermethylation. So this is a silencing epigenetic mark that also results in reduced transcription of and production of collagen. And that altogether results in those issues with bone turnover, but also vascular complications in scurvy. And treatment is quite simple. It's vitamin C. After 2 days of high-dose vitamin C, our patient did not have any bone pain, and the bleeds disappeared over the next weeks. The number of primary metabolic bone disorders that needs to be considered, rickets disease or rachitis, which is less commonly used, is one of them. Rickets is caused by vitamin D deficiency. There can be the results of various issues. Calcium and phosphate are low in the serum, and alkaline phosphatase is increased as a sign of increased bone turnover. That results in secondary hyperparathyroidism because the body tries to increase calcium calcium and phosphate levels in the blood, and that results in disturbed bone mineralization and very soft bones, which can result in bending of long bones, such as in the legs on the left. It results in widened ribs and also metaphyseal regions of long bones close to joints. McCune-Albright syndrome is a significantly less common condition, or even rarer condition. It's a neurocutaneous disease that's characterized by a clinical trias consisting of café au lait spots, fibrous dysplasia, which you can see on the X-ray that can result in pain, and then pubertus precox that can come along with acromegaly and small stature. Another condition which we need to consider, especially in pediatric rheumatology, is hypophosphatasia. It's also very, very rare, and it's caused by reduced activity of alkaline phosphatase that is caused by mutations in the gene encoding for alkaline phosphatase. There are very severe phenotypes that result in death, usually within the first year of life, but there are also milder forms. Some of them show some degree of dysmorphia, which are then easier to diagnose, but there may be patients who only show the clinical picture of chronic non-bacterial osteomyelitis or CRMO with diffuse bone pain and pictures similar to the scurvy patient previously. So this is why we test alkaline phosphatase in all patients suspected to have CRMO, and if they are low for age or lower than the normal range across age groups, we definitely need to consider hypophosphatasia. There are a number of skeletal dysplasias that do come along with bone pain. Some of the ones you know better is osteogenesis imperfecta. That's also a condition we don't see in pediatric rheumatology because it gets diagnosed very early in life, sometimes even before birth. It's a defect in collagen 1 that can be inherited dominantly or recessively. And as I said, usually it's diagnosed very early in life as it results in osteopenia and fractures. Osteopetrosis, also usually not seen in pediatric rheumatology, basically is somewhat of the opposite of osteogenesis imperfecta. It is caused by congenital osteoclast malfunction. Also follows recessive or dominant traits of inheritance, and it basically results in increased bone mass and very frequently also with dysmorphia. Something that is more important to consider, because it can actually be invisible, is a group of conditions that are referred to as dominant multiple epiphyseal dysplasia. As I said, it's a group of conditions that is characterized by usually very mild skeletal dysplasia. It only affects 1 in 20,000, so it's quite rare. It does cause joint pain, especially of hips and knees, and those pains develop during the development. So 6-year-old, 8-year-olds usually will start having symptoms. It can result in progressive joint disease, particularly of large weight-bearing bones, but that actually doesn't have to occur. Some patients are relatively mildly symptomatic or other than pain asymptomatic. So in families with short stature and a family history of pain, chronic bone pain, this is actually a differential diagnosis that needs to be considered even in the absence of dysmorphic features. There are 5 different collagen matrix related genes that can cause this condition, and one of them is collagen 9A, and that's, I think, also the most commonly affected of the group. Another differential diagnosis that you may come across in pediatric rheumatology is progressive pseudo-rheumatoid dysplasia, or PPD. It's a condition that gets worse over time. So these are all pictures from the same individual starting at 5 years of age, and the last picture I think was taken at 20 years of age. And this is this progressive contracture of finger joints that is associated with widening around finger joints. So this can actually clinically look very similar to polyarticular juvenile idiopathic arthritis. And there are also bone changes that are progressive over time, and these are actually quite specific for that condition. And the experienced radiologist will tell you right away that this could be PPD. And the diagnosis can be made definitively after sequencing of the CCN6 gene that was formerly known as WISP3. And those patients obviously will not show relief in response to anti-inflammatory or immune modulatory treatment. There are a number of other skeletal dysplasias that can be associated with bone pain. Osteochondrodysplasia is one example, which you can see in these pictures, but I won't be able to actually go through more also because of limited time. Growing pains is a diagnosis that's made quite frequently by pediatricians and also sometimes pediatric rheumatology. There is no exact case definition for growing pains, and some colleagues would even claim that this is more of an excuse than a diagnosis because we don't find the underlying pathology that is associated with pain experienced by children. Usually shooting bone pain in the evening or at night is diagnosed as growing pains. It's quite typical that there are no pains on the following morning and that there are symptom-free intervals that can last weeks to even months before it comes back. An entire 10 to 37% of children in Western nations report growing pains at some points in their life, and it usually is prevalent in younger children, in kindergarten children or young school-age children. Etiology is actually unknown. The question is it truly associated with growth? That's not quite clear because children also grow a lot during puberty, and in puberty growing pains are a diagnosis that's made very uncommonly or never. There is a question whether there are associations with neurodevelopment, whether there are relations to daily activity levels, since the pain happens at night, and for the same reason hormonal influences have been discussed as well, but there is no evidence for them. Overall, especially since there is no exact case definition, it is a diagnosis of exclusion, and differential diagnosis required to be excluded, especially malignancies, which brings me to the next group, malignancies and hematological conditions. Bone pain is actually quite common in malignant and hematological disease. Symptoms and pain quality can vary quite a bit, so we may see localized bone pain in primary bone tumors, metastases, necrosis, and bone infarctions, and more diffuse musculoskeletal or bone pain in primary bone marrow disease. The pathogenesis of pain is not completely clear. Sorry, just something is popping up on my screen here. The pathogenesis of pain is not completely clear. There may be mechanical factors through infiltration of tumor cells into the periost or the bone, increasing the pressure and therefore resulting in pain. Nerval pain, inflammatory or humoral factors may play a role, especially prostaglandins, which are being released by some tumors I'll talk about in a couple of minutes. They sensitize pain receptors and therefore trigger pain, histamine, serotonin, and also rank ligand. And rank ligand actually results in the activation of osteoclasts and increased bone turnover. Osteosarcoma is the most common primary bone tumor with a peak onset in the second decade of life. It usually affects the distal femur, tibia, and fibula, and these three locations make up for 70% of all patients. Humerus can be affected as well in about 10% of all cases, and it usually affects the metaphyseal region of those bones. And as you can see in this picture, sometimes osteosarcoma can come along with huge swellings around joints, which is why initially colleagues may think of arthritis. And as it initially also causes very non-specific bone pain, it can take months until a final diagnosis has been made, and up to half a year has been reported. Ewing sarcoma is another bone tumor. Ewing sarcoma shows equal distribution between extremities and the axial skeleton. If it's affecting the extremities, it usually affects the lower extremity in about 80% of those cases. Other than osteosarcoma, it usually affects the diaphyseal region of the bones, and 1/3 of patients at the time of diagnosis have fever, anemia, leukocytosis, elevated citrates, and other signs of systemic disease. And here are pictures of a patient with Ewing sarcoma starting from a rib, and you can, on the bottom right of this slide, you can see the bone destruction that was caused by this osteosarcoma. Acute leukemia can cause diffuse bone pain, and in some cases even joint swelling, and therefore ALL as well as AML are differential diagnoses to juvenile idiopathic arthritis, and especially in ALL, up to 50% of all patients have bone pain. And there are even some patients who were misdiagnosed and seen by rheumatology specialist services with JIA who ended up to have ALL. A number of hematological conditions can cause bone pathology and bone pain. For example, sickle cell anemia. In this case that I got the pictures from, it resulted in osteonecrosis and diffuse bone pains. A number of clotting disorders can result in joint or bone pain. So these images are from patients with hemophilia A. Hemophilia A, for example, can result in bleedings into large joints, such, for example, the knee, which can be misdiagnosed initially or at least trigger a differential diagnosis of arthritis. And in the end, it's a clotting disorder. Benign bone tumors can cause bone pain and even swelling. One of them is osteoid osteoma. That's a very important differential diagnosis. It frequently affects the legs, but can generally occur anywhere. We had patients with fingers, small finger bones affected, or also the vertebral spine affected. It is a tumor that you will see in children and young adults. It basically never happens in individuals past the 40th to 50th birthday. It usually triggers nighttime pain, and that's quite characteristic for it. And it can even cause arthritis if it happens close to joints. What you can see down here on the X-ray is bone sclerosis. That's quite typical. And then the MRI issues showed that, that a characteristic nidus formation, which is then also diagnosis giving, and can be seen on MRI or CAT scan images. Osteoblastoma is significantly less common as compared to osteoid osteoma. It's also an osteoid tissue forming a primary bone tumor. There are some similarities to osteoid osteomata, which is why some colleagues refer to it as the big sibling of the osteoid osteoma. And it may be a variant of the same disease. However, sometimes osteoblastoma can grow aggressively, so therefore it's not completely clear if it's the same condition. What is common to both of them are very high levels of prostaglandin formation, and that can result in quite severe pain. And in osteoblastoma, since huge amounts of prostaglandins are being produced in this patient, we saw the clinical picture of CRMO. So this individual had diffuse bone pain and even signal alterations in multiple long bones, and we treated this patient with naproxen, a non-steroidal anti-inflammatory drug, to reduce prostaglandin formation. That actually resulted in relief of all symptoms. And this tumor affected the vertebral spine, and therefore we didn't perform surgery, but they need to be monitored quite closely because they can show some aggressive growth in rare instances. Osteochondromatosis can come along with bone pain. In very disseminated cases, it's referred to Ollier's disease. You can see the chondromas here. In childhood, this usually is a benign condition, but there can be malignant transformation in adults, which is why adults need to be monitored when diagnosed with this condition. You should not perform X-rays and definitely not perform CAT scan in these individuals, also not to monitor disease activity, since those tumors are radiosensitive and that can actually trigger malformation. There are many, many other benign bone tumors that can or should be considered, including fibrous metaphyseal defects, multiple exostosis, chondroblastoma or chondromyxofibroma, which I can't talk about in detail in this presentation. One rare tumor that is actually associated with synovialitis is pigmented villonodular synovialitis, or PVNS. And this is a very rare condition that actually does result in inflammation of the joint, but it does not really respond well to steroid injections or biologic or DMARD treatment. It is being diagnosed by the MRI, so these findings are somewhat characteristic, and then confirmed by synovial biopsies. And when this diagnosis is made, it usually results in complete removal of the synovial membrane. And since this is difficult, it should be performed in a specialized center. We heard about the issues differentiating between articular and periarticular swelling, especially in young children. So for this reason, arteriovenous or venous malformations initially may appear like arthritis and even result in some articular pain. And while they are rare, they still need to be considered. And that's one of the reasons why we need to perform imaging to make a diagnosis of JRE. There are a number of activity-related bone pathologies and osteochondroses that I just want to run through real quickly. Patellofemoral instability may result in subluxation of the patella. This is associated quite frequently with hypermobility we talked about earlier. Osteochondrosis dissecans, as you can see here, is associated with increased physical activity. So are stress fractures. The image down there was from a patient with osteopenia as a result of short bowel syndrome, and when she played on a trampoline, she developed pain afterwards, and that was the reason. There are a number of conditions that are important to consider in pediatrics. Morbus pertis can cause knee pain or hip pain, and lastly result in osteonecrosis of the femoral head. That's a very important differential diagnosis, especially in younger boys. Musculoskeletal disease is associated with increased physical activity. It is a pathology of the tibial tuberosity, but there can be basically all small bones adjacent to joints can show osteonecrosis or inflammation as a result of increased activity. In those cases, we usually treat with novel anti-inflammatory drugs, and this is quite painful and can be a quite lengthy experience. Pain amplification syndrome is basically a talk for itself. I want to touch on that only very briefly. Pain amplification can follow variable clinical patterns. It can include a complex regional pain syndrome, idiopathic pain, and what adult rheumatologists call fibromyalgia. We don't really use that term in pediatric rheumatology anymore, since it basically puts a stamp on patients and indicates that this is a diagnosis for lifetime that may not go away, which we feel is not a good thing to do because we can work on that. Pain amplification is characterized by disproportional pain or disability, sometimes as a result of very, very minor trauma. CRPS is associated with very severe pain, autonomic dysfunction, and skin atrophy or dystrophy is very rare in children, so that's quite uncommon. Therapy includes aggressive physiotherapy and psychology, so the multidisciplinary approach is very, very key to these patients. Idiopathic MSK pain, I talked about some of the things before, so some hypermobility cases may be classified as idiopathic musculoskeletal pain, but they may also be the result of previous arthritis in the context of JIA. And lastly, fibromyalgia is a diagnosis we don't make in childhood, but it could be made in individuals with typical pain patterns. Some of them have trigger points like in adulthood, sleep disturbance, headaches, fatigue, morning stiffness is even present in up to 10% of all patients. And also here, the multidisciplinary approach with physiotherapists, increased physical activity and psychology is key. And as soon as that diagnosis is made, further investigations need to be stopped and multidisciplinary approaches need to be taken. The last topic are neuropathies, and especially worth mentioning, I feel, is small fiber neuropathy. And I'm mentioning this since it likely covers a variety of conditions, including diabetic neuropathy, metabolic syndrome, viral infections, but also associations with autoimmune disease, including juvenile idiopathic arthritis. So symptoms are somewhat variable. They usually are associated with burning and shooting pains that can happen or be worse at night time. There is some degree of allodynia and hyperesthesia, and it usually shows distal onset. So that's also a reason why you should, and that moves proximally. So that's also a reason why you should do skin biopsies, which I'll get to in a minute, in a distal region and not in the groin area, for example, because then you actually may miss it, especially in early cases. In some patients, you will find autonomic or enteric dysfunction, and those images are from a patient who was 14 years old when we saw her, and she came to our hospital with significantly reduced perfusion of her hands and feet and Raynaud's-like phenomenon, but it looked like she was wearing gloves, so the edge of or the rim of this was like very, very sharp. So we treated her with calcium channel blockers, which improved it and made the hands nice and warm to the next morning. So that's a residual on the next morning, and you can still see some discoloration. Also, this MRI was taken the next morning, and you can see that significantly reduced perfusion of the peripheral extremities. Diagnosis is made by history and clinical exam, sometimes neurophysiology, but you will only find pathology if also larger nerves are affected. And last but not least, skin biopsy, which should be done at distal extremities. And what you can see here is the typical pictures. At the typical picture with the epidermal region showing significantly reduced numbers of those small fibers on the left as compared to the normal result on the right. Agreed treatment includes antidepressants, anticonvulsives, opioids, topical treatment, for example, with lidocaine, and physical treatment. Calcium channel blockers are actually not part of the expert recommendations, but we did use that in some patients with these autonomous dysregulations and reduced perfusions, and they worked very, very well in those patients. And some of those patients we've seen actually had a diagnosis of systemic autoimmune disease or JIA up front. So it actually remains to be discussed whether this can be the result or the cause for pain amplification in some patients who had autoimmune inflammatory disease before. So summing this up, chronic pain is a symptom and not a diagnosis. There is a number of underlying causes, which include, but certainly aren't limited to hyper, but also hypomobility syndromes, storage disease, metabolic and endocrine conditions, skeletal dysplasia, growing pains, malignancy and hematologic disease, benign and benign bone tumors, bone and skeletal malformations, activity-related conditions, osteochondrosis, pain amplification, and this, I think, especially needs to be seen in the context of neuropathology, such as small fiber neuropathy. And I know this was a lot, but I hope you've been able to enjoy it at least a little, and I'm happy to take questions later. Thank you very much.
Thank you so much, Professor Hedrich. Thank you, Christian. That was a fantastic overview of all the conditions that we can encounter with non-inflammatory pain. Questions will be at the end through the Q&A. So we will move to the third presentation of this session, which is Professor Kirsten Minden, which will tell us about the most common extra-articular complication of inflammatory arthritis, which is eye involvement, which sometimes is not so well known by pediatricians. So Kirsten, the floor is yours.
Yeah, thank you very much, Rolando, and thanks to the organizer. So it's a great pleasure for me to talk about special manifestations of rheumatic diseases in children. Yeah, you have already heard about how to examine a child with rheumatic complaints and the challenges in diagnosis and treatment of pain syndrome. So we will now focus on one of the smallest organs of our body, the eye. But before, here are my disclosures. So you may wonder why it's becoming so special now in this rheumatological session and what a pediatrician has to do with the eye. Normally, ophthalmologists take care of this lightweight, complex, very important sensory organ of our body that absorbs 10 million pieces of information every second and transmits them to the brain. So I hope to answer this question within the next minutes, but also the following questions. Which eye manifestations occur in children with rheumatic diseases? What is their risk? How common are they in children with rheumatic diseases? Who has a particularly high risk? And how do we recognize and treat eye manifestations in children with rheumatic diseases? And I will address the who, how, and what by focusing on inflammatory rheumatic diseases that are the diseases that dominate the everyday life of pediatric rheumatologists. And these diseases, chronic arthritis, autoinflammatory diseases, connective tissue diseases, and vasculitis, they together affect at least 1 in 1,000 children and adolescents. And among them, the most frequent disease is juvenile idiopathic arthritis, or JIA, with a prevalence of 60 per 100,000 children and adolescents, according to a meta-analysis that involved 43 studies. So in comparison to JIA, autoinflammatory diseases and connective tissue diseases are about 10 times less frequent, and vasculitis are even 100 times less frequent. And all these diseases are systemic diseases, and they can affect not only the joints and the skin, as you can see here, but also several organs, including the eye. And in almost all of them, an eye manifestation in the form of an inflammation can occur. The inflammation can occur in any part of the eye, in the conjunctiva, in the 3 layers of the eye, the outer layer with cornea and sclera, the middle layer, the uvea, and the inner layer, the retina. Of course, in daily practice, we most frequently encounter conjunctivitis, but mostly in children with allergic diseases and infections, and currently also in children with COVID-19. A cross-sectional study of more than 200 children hospitalized with COVID-19 in Wuhan, China, has informed us that 1 in 4 children had conjunctivitis and 18% as initial manifestation of COVID. Conjunctivitis was more common in the children with systemic symptoms and cough than in those without these symptoms. However, conjunctivitis is not yet considered a warning sign that allows early diagnosis or predicts a severe course of COVID. In contrast, conjunctivitis is a diagnostic indicator and part of diagnostic or classification criteria for some rheumatic diseases. And this is the case, for example, with the most common vasculitis in children under the age of 5. And here, a bilateral non-exudative conjunctivitis, which usually begins shortly after the onset of fever and often spares the limbus, a vascular-free zone around the iris, indicates the disease, Kawasaki disease. And here, conjunctivitis is one of the 5 principal clinical features that, in addition to fever, are used to diagnose this vasculitis. But conjunctivitis is also a typical manifestation of autoinflammatory diseases, such as the periodic fever syndromes, TRAPS and CAPS, and especially in TRAPS, conjunctivitis and eyelid edema, which occur in the acute phases of the disease and can be seen in this little boy, are pathognomonic and often point the way to the diagnosis. However, these diseases are very rare. The outer layer of the eye with cornea and sclera is rarely affected in children with rheumatic diseases, more rarely than in adults, where keratoconjunctivitis sicca and scleritis are observed in about 25% and 5% of patients with rheumatoid arthritis, respectively. The retina can also be affected in children with rheumatic diseases, but this is again rarely the case, for example, in rare diseases such as lupus or vasculitis. What pediatricians and pediatric rheumatologists fear, however, is a much more frequent involvement of the middle layer of the eye, the uvea. The name uvea comes from the Latin word for grape, because Roman anatomists felt that peeling away the outer layer of the eye left a grape-like structure. So the uvea is, if you will, the vascular coat of the eyeball and is composed of 3 parts: the iris, the ciliary body, and the choroid. Estimates from Europe and North America suggest that the prevalence, the overall prevalence of uveitis is roughly 1 in 1,000, with children accounting for 10 to 15% of all cases. And despite its relative rarity, uveitis accounts for 10% of worldwide blindness and approximately the same amount of visual morbidity as either macular degeneration or diabetic retinopathy, which is unknown to most of the population. And while macular degeneration or diabetic retinopathy are diseases that occur towards the end of life, uveitis might start in childhood and persist through decades. So according to the primary side of inflammation, and based on a consensus of international experts on the nomenclature of uveitis, uveitis is classified into anterior, where the primary side of inflammation is the anterior chamber; intermediate, where the primary side is the vitreous; and posterior, where the primary side is retina or choroid. In children, however, the most common form of uveitis is anterior uveitis. Of course, not every uveitis is associated with the rheumatic disease. There are many causes, infectious, non-infectious, and masked causes, but In Europe, in developed countries, the most common form of uveitis in children is non-infectious, occurring for about 80% of cases. And the non-infectious uveitis is very often associated with an immune-mediated systemic disease. According to a recent meta-analysis, uveitis occurs in 13% of cases with juvenile idiopathic arthritis, and 24% with spondyloarthritis, and less frequently in connective tissue diseases. But since JRA is the most frequent chronic rheumatic disease and much more common than the other rheumatic diseases, JRA is the most common systemic disease underlying childhood uveitis. The coexistence of uveitis and arthritis has been known for a long time, but it is still not well understood but nevertheless, the coexistence suggests common pathogenesis. And analogous to arthritis, uveitis is thought to be due to an imbalance between the regulatory mechanisms that inhibit the immune system and the inflammatory mechanisms that have evolved to rid the body of infectious organisms, but which can lead to immune-mediated, often chronic disease if employed outside the context of an infection. And this abnormal immune activation appears to be a combination of environmental triggers and genetic risk factors that tip the balance away from immune regulation and toward uncontrolled inflammation. Some of the key inflammatory cytokines that can either act on or are produced by inflammatory cells are TNF-alpha, IL-6, and IL-17. And these cytokines and others are being investigated as potential targets or have already been identified as successful targets for the treatment of uveitis. So in the most common chronic rheumatic disease in children, uveitis is the most frequent extra-articular manifestation. And I will now go into more detail about this common rheumatic disease. JRA is defined as an arthritis of unknown etiology that begins before the age of 16 and persists for at least 6 weeks. And you know, JRA is not a single disease. According to the current EILA classification, we distinguish these 6 defined onset categories, which are listed here in descending order of their relative frequencies. And this classification is based on their clinical pattern, namely the number of affected joints within the first 6 months of disease, extra-articular manifestations, family history, and some laboratory parameters. And these different types of JRA differ in their genetic background, response to treatment, disease outcome, but also regarding eye involvement. So you see in Europe, the most common type of JRA is oligoarthritis. And this is a typical patient, a girl with inflammation of the left knee joint and a finger joint. And the girl shows it is a little girl. Oligoarthritis usually begins at the age of 2 to 3 years and affect preferably girls. A maximum of 4 joints is affected within the first 6 months of disease, and these are mainly the knee and ankle joints. If more than 4 joints are affected over time, the disease is then referred to as extended oligoarthritis. Laboratory parameters are not very helpful to diagnose oligoarthritis. Inflammatory parameters are often normal, as shown by these mean values observed in large JRA inception cohorts. Autoantibodies, in fact, anti-nuclear antibodies, they are detected relatively frequently, but due to their low specificity, they don't really help in making a diagnosis. These antibodies can, for example, also detected in about 1 in 5 healthy school children. However, these antibodies help to estimate the risk of uveitis. Uveitis develops about 2 to 4 times more frequently in ANA-positive patients than in ANA-negative patients. So the second most common form of JRA is rheumatoid factor negative polyarthritis. And as the name implies, many joints are already affected at the beginning of disease, as in this girl. And you can see the considerable swelling on the back of her hands due to tenosynovitis and the flexed positions of elbows, hips, and knees due to arthritis. Apart from the number of joints affected, polyarthritis is no different from oligoarthritis. It also typically begins in early childhood and also affect mainly girls. And here, a symmetrical arthritis can often be seen involving the small and the large joints. And the inflammatory parameters can, even in patients with polyarthritis, completely unremarkable, which one might not expect in polyarthritis. These two most common JRA categories together account for about 2/3 of all JRA cases, and on the other hand, for almost 90% of all uveitis cases in JRA. And it is precisely in this group that uveitis begins usually insidious and asymptomatic. That means the children have a wide eye, no photophobia, and no pain. The third most common JRA category, enthesitis-related arthritis, usually starts at adolescent age. And it is the only JRA type that prefers boys. An asymmetrical oligoarthritis is often present, as in this boy who has an arthritis of the left knee. Enthesitis, an inflammation of the sites where tendons, for example, Achilles tendon, ligaments, and capsules attach to bone. And this is typical and gave the disease its name. But there are other typical features, for example, the inflammation of big toe joints, tenosynovitis, tarsitis, and sacroiliitis. But uveitis can also be observed in patients with this disease. And this uveitis is different from that in oligo and polyarthritis because it's usually acute, symptomatic, unilateral, and as you can see, the eye is red. In adolescents with this type of JRA, arthritis and enthesitis are clinically predominant. And as in oligoarthritis, the large joints of the lower extremities are primarily affected, but here the hip joints are also often included, and this is very rarely the case in patients with oligoarthritis. HLA-B27 is a hallmark of this disease. So you have now heard about the characteristics of the 3 most common JRA categories, and here is a summary of the characteristics in terms of uveitis frequencies, symptoms, and laboratory characteristics for all JRA categories. Uveitis occurs most frequently in oligoarthritis, followed by those with rheumatoid factor negative polyarthritis and early onset psoriatic arthritis. And in these patients, the uveitis is typically asymptomatic, bilateral, and takes a chronic course. Enthesitis-related arthritis and psoriatic arthritis, these patients show uveitis symptoms that we know from adults with spondyloarthritis. These patients have a red and painful eye. And there are also categories in which we don't expect uveitis, and these are the patients with rheumatoid factor positive polyarthritis and systemic JRA. So we know patients with oligoarthritis have the highest risk of uveitis. However, oligoarthritis, these patients account for almost half of all new cases with JRA. So the question is, who gets uveitis in this large group? And recently, risk factors of uveitis could be identified and include the age at onset, ANA positivity, and an elevated ESR. And these factors together influence the risk, and this is illustrated here. So patients with an onset of arthritis beyond the age of 3, with a normal ESR and without anti-nuclear antibody, have a low risk of uveitis. But if ANAs are detected, the risk increases but remains below 5%. The risk increases further if the ESR is above 20 millimeter per hour, and even more if the JRA started already in the first 3 years of life. So the high risk group of uveitis are the very young ANA-positive patients with increased inflammatory parameters. The risk of uveitis is highest at the beginning of the disease, and this is illustrated here by a probability plot. About 5% of patients develop uveitis even before the onset of arthritis, and in about half the cases, the uveitis manifests within the first 12 months of the disease. In the following years, then the number of new cases decreases. And if this uveitis isn't diagnosed and treated in time, structural complications can quickly develop. And the most common complications can be seen here, and these are adhesions between iris and lens, which makes the pupil appear so asymmetrical, followed by cataract and ocular hypertension. And these complications have an impact on the outcomes, as they often lead to a relevant visual loss, even up to blindness. A systematic literature review looking at the outcomes of JRA-associated uveitis showed a visual acuity of less than 0.5 in almost 10% of uveitis patients. From recent JRA cohort studies, we know that such complications already exist in every third patient at the time of diagnosis of uveitis. And during the first 2 years of observation, the overall rate of complications increased only slightly further. So the main problem of uveitis is therefore its late detection due to its mostly asymptomatic manifestation. In daily practice, therefore, uveitis should be considered in every child suspected of having JRA, especially young children. And the time to diagnosis of uveitis can be shortened if you refer a child with arthritis or suspicion of JRA, not only to a pediatric rheumatologist, but also to an ophthalmologist. The ophthalmologist is able to exclude or diagnose uveitis by a slit lamp examination. And this allows the recognition of inflammatory cells and adhesions, as in this case here. According to current international guidelines, all children with JRA should be seen by an ophthalmologist promptly after the diagnosis of JRA and periodically thereafter. And the frequency of uveitis screening depends on the JRA category and the presence of risk factors, namely age at disease onset, ANA positivity, and disease duration. And patients with the here red marked JRA categories, disease onset before the age of 7 and ANA positivity, should be screened every 3 months within the first 4 years of the disease. And those who are ANA negative, have a later disease onset or other JRA categories, they can be examined less frequently. Of course, the aim is to detect uveitis as early as possible. And once uveitis is detected, it usually requires immediate treatment. More and more data indicate that the earlier JRA is treated and the earlier an inactive disease is reached, the better the outcome of JRA, especially the likelihood of achieving a drug-free remission. And therefore, the aim is to achieve an inactive disease or controlled uveitis within the first, at least within the first 12 months of treatment. So topical corticosteroids are still the mainstay of treatment, although these drugs should be limited in duration and dose. The rapid development of novel treatments for JRA, which brought us all these new biological and other disease-modifying anti-rheumatic drugs, has of course transformed our uveitis treatment. And current treatment recommendations have emphasized the early use of steroid-sparing DMARDs, in particular methotrexate, if uveitis inactivity can't be achieved within the first 3 months of treatments, or if a steroid reduction to 2 drops per day isn't possible. Methotrexate is the DMARD of choice. About 3/4 of patients respond to this therapy. Methotrexate is not only effective in treating uveitis, it can also protect against uveitis, because it could be repeatedly shown that children treated with methotrexate develop uveitis less often than children with JRA not treated with methotrexate. And if methotrexate doesn't control the uveitis sufficiently or isn't tolerated in the long term, biologic DMARDs are recommended. The only approved drug for uveitis, at least at the moment, is the monoclonal TNF antibody adalimumab, which could be shown to be effective and safe. Other TNF antibodies are alternatives. About 3/4 of patients respond to an anti-TNF treatment. And if 2 different TNF antibodies have failed, abatacept and tocilizumab are further treatment alternatives. And with these treatments, we achieve an inactive disease in over 90% of patients in clinical practice. Unfortunately, the risk of uveitis recurrence after discontinuing methotrexate or biologics is similarly high for uveitis as for arthritis. That means more than half of patients experience a disease flare after DMARD discontinuation within 12 months. So treatments are often required over long periods of time and often into adulthood. And therefore, at least half of these patients require specialized care into adulthood. But the new treatments have, of course, improved the long-term outcomes of our patients. The frequency of ocular complications has decreased during the past 20 years, but almost 1 in 6 children and young people still develop severe visual impairment, at least in one eye, before adulthood. So uveitis in children is and remains a diagnostic and therapeutic challenge. And this brings me to my take-home messages. Rheumatic diseases in children are often associated with eye manifestations, mainly uveitis. The diagnosis of JRA and associated uveitis is reliant on clinical features rather than serological or genetic investigations. Inflammatory eye diseases in children are often asymptomatic, leading to delay in diagnosis and causing a distinct challenge for treatment. Despite better treatments, vision-threatening complications are still significant. And an early referral to and regular checkups by ophthalmologists are necessary to further improve the outcomes of our patients. So, and this brings me to the end. I would like to thank you very much for your interest and listening.
Thank you so much, to Professor Minden. So that was the third presentation of this session, and we do have questions. We have actually 2 questions for Professor HEDRICH and 3 questions for Professor Minden. I will read the questions, the two of them together, no, one by one. First to Christian. The first question is, I have been stuck with children with joint pains without any pathology. Given the limited investigative facilities where I practice, is there such a thing as growth pain? How common? Christian, can you give a short answer to this colleague?
Yeah, so as I tried to point out, there is no case definition for it that is widely accepted. So there are estimates that up to 37 to 40% of all kids in Western nations at some point report what we diagnose as growing pains. So it definitely is a diagnosis of exclusion. If it's not unilateral and only at nighttime, which then makes it more likely to be a benign bone tumor like osteoid osteoma, and you ruled all these out, though some colleagues may claim this is an excuse for not finding anything else, it doesn't matter. Reassurance and telling families that this will most likely disappear over time, give medication as needed. Lots of kids actually respond very well to massaging the extremity that hurts, is probably fine. It's just very important to exclude malignancy, especially if it's diffuse pain, and that can be difficult, but then you need to monitor those individuals in the beginning more closely, look for signs like blasts in the blood, LDH or uric acid in the blood. If it's a very chronic thing and you didn't find anything else, it's only at nighttime, there are long periods without symptoms over weeks or months, I think you can make that diagnosis and reassure families that this will most likely go away. And it does in most patients.
Okay, the second question is connected to the first one, which is, would you mind detailing the pattern of arthritis of non-bone malignancies, knowing well that CBC can be normal in early leukemia, presenting with rheum symptoms? Can they be migratory? What malignancy screens will you do?
Well, that's a very, very good question, and a very broad question that probably can keep me talk for half an hour. It's pretty much dependent on the individual history. So if you see a patient who had diffuse bone pain for 12 months, which is something we see quite commonly in our tertiary care center, that we don't need to exclude ALL anymore because there were symptoms for 12 or more months, normal blood counts, normal LDH and uric acid. It's very, very different if you have a patient who had symptoms for 4 to 6 weeks, potentially even with polyarticular arthritis, like in these conditions or circumstances, you do need to consider malignancy such as ALL. And especially in antibody negative polyarticular arthritis patients, let's say a 7-year-old boy without rheumatic factor and polyarticular disease, I always do a bone marrow independent of uric acid if it's a short history. And we did pick up not just one, it was like 2 or 3 patients who looked like polyarticular JIA, short history, and they did have ALL in the end. So it plays a big role how long it's been going on. If it's only a couple of weeks, I would be very, very cautious. And I know that I'm spoiled by working in huge medical centers where we can get an MRI right away, where we can do a bone marrow right away. So if you see a patient with new bone pain, couple of weeks, the least thing you should do is to, monitor bloods over the first couple of weeks and see if anything changes, because you're absolutely right with the question. In the beginning, it may be normal, and 3 weeks later, he has blast, uric acid, and LDH. So it's a very difficult and very good question.
Thank you very much. Now there are 3 questions, short questions for Kirsten related to uveitis, and I will read the 3. They are very short. Does the activity of arthritis correlate with that of uveitis? How often does blindness occur in children with JIA today? And do corticosteroid injection into the eye have a place in the therapy of uveitis?
Okay, then I will start with the first one. So I can make it short. Arthritis and uveitis don't correlate in terms of activity. So there may be children that have persistent or recurrent arthritis, while uveitis has resolved very quickly. But it can also be the other way around. And recurrences can also occur either in the eye only or in the joint only. So the reason for this is still unknown. Therefore, for example, uveitis screening is necessary even if there is no active arthritis. So I hope this answers the first question. To the second, how often does blindness occur? I didn't report on this because the numbers are not so clear. I would assume that almost in every pediatric rheumatology center, there is still at least one child with JRA-associated uveitis who is blind. But this is at least the case here in Berlin. And recent outcome studies reported varying visual acuity rates of 0.1 in at least one eye in up to 20% of these patients. But we have to keep in mind that these data often come from tertiary referral centers, and these, of course, have higher rates. But what we can say is that unfortunately, blindness is not a historical outcome, but is still present, and it is mainly caused by secondary glaucoma, macular damage, and hypertony. So, and then the third question relates to corticosteroid injections into the eye. Yeah, our intra-articular corticosteroid treatments to treat arthritis is a first line treatment, but it's a bit different with regard to intraocular corticosteroid injection. So we have a high risk of steroid-induced ocular hypertension and glaucoma as consequence of intraocular or periocular corticosteroid injections. And so we consider this treatment as a last resort treatment or as a temporary measure for patients with JRA-associated uveitis and macular edema, for example, who haven't responded well to systemic treatments. So it's rather last treatment.
Thank you so much. I think that there are no more questions, and therefore I think we can close this session. I thank very much for the speaker. It was a very interesting session. I ask the audience if they have any further suggestions for next year or any comments on the talks or any questions after the meeting to relate to the organizer, that they can forward it to me. And therefore, there is a short break before the next rheumatology session. We have another rheumatology session, actually two. The next one will be on the skin and the joints. So goodbye to everyone, and we will see you in the next session in about 20 minutes.